Excellent. Well, welcome everybody to our first breakout session here today, our third day of the reverse site visit. And this is a session on improving population health performance. My name is Tracy Morton. I'm the Director of Population Health at the National Rural Health Resource Center and the Program Manager for TASK, which works with the 45 state flex programs. So thanks so much for joining us. A couple of things to kind of get us oriented to the room, and then I'll introduce the session and the speakers. This breakout session is being recorded, and the playback will be made available in the attendee hub here shortly after the session is completed. So you'll be able to watch it again at your leisure, or suggest it to other participants that might have been attending the conference that you'd like to share it with as well. If you do need any technical support during this, go ahead and send us a message in the chat box, which the chat icon is found kind of directly at the bottom menu of your screen. And let us know if you need any assistance, and we'd be happy to support you and help you out that way too. If you have questions for the presenters, I encourage you to type those into the chat box as well. And myself and Patricia Gale will be monitoring that, and we'll let the speakers know that there are questions in there if they happen to not catch them themselves. And so with that, I'd like to welcome you and introduce to you what this session is really about. So this session is being presented by our partners over at the Flex Monitoring team. And they're sharing resources and information to help the state flex programs develop some initiatives to improve population health performance of critical access hospitals, and in turn, the health of the rural communities. This presentation will explore promising population health initiatives implemented by state flex programs, resources that can assist critical access hospitals in implementing mental health, substance use, public health, and chronic care management services, and then strategies to monitor the impact of state flex program population health activities. It'll also describe a pathway to connect the Flex program population health efforts to the U.S. Department of Health and Human Services Healthy Rural Hometowns Initiative, which is a 5-year multi-program effort across the federal government to address factors that are driving rural disparities in heart disease, cancer, unintentional injury, chronic lower respiratory disease, and stroke. So I'd like to introduce to you our 5 panelists today. First, Sarah Contraster is a policy associate at the University of Southern Maine, working as part of the Maine Rural Health Research Center and the Flex Monitoring team since 2015. Sarah's portfolio with the Flex Monitoring team focuses on evaluation of state flex program activities across program areas, on critical access hospital-based interventions to address the continuum of care around substance use disorders, and population health improvement. She's worked with the Maine Rural Health Research Center to examine the closure of inpatient psychiatric beds in rural communities. And during her time at the University of Southern Maine, Sarah has collaborated extensively with the Maine Health Access Foundation, serving as the evaluator for their Rural Health Transformation Grant Program and co-authoring the Maine Rural Health Innovation Briefs. Celia Jewell is a policy analyst at the Maine Rural Health Research Center, again, a member of the staff there at the University of Southern Maine and of the Flex Monitoring team. And Celia contributes to projects utilizing applied research methods that focus on critical access hospitals, rural healthcare delivery systems, in the policy environment. A sample of Celia's work and current projects includes evaluating critical access hospital population health activities and their corresponding measurement strategies, and identifying rural relevant emergency medical service agency licensure elements, and then examining the relationship between poverty and the health of rural versus urban residents. Prior to joining the Flex Monitoring team, Celia worked in the healthcare industry as a nurse providing care to patients in the critical care, post-anesthesia care, oncology, and community health settings, and is a program manager for a rapidly expanding palliative medicine practice. She's worked both collaboratively stateside and abroad on numerous public health initiatives to improve the health of rural populations. And then joining Celia and Sarah is John Gale. John Gale is a senior research associate and the director of policy engagement, again at the University of Southern Maine, is part of the research center there. John has extensive experience, 24 years of experience in rural health research and 16 years of experience managing primary care and behavioral health practices. And his work concentrates on rural delivery systems, including rural health clinics, critical access hospitals, community engagement, substance use, mental health, and primary care, as well as emergency medical services. And John has worked both nationally and internationally. Underlying his work is a focus on engaging rural communities in building delivery systems that meet their priority needs, efficiently using scarce local resources, and providing equitable access to resources to ensure health that are sustainable over time. And John is the immediate past president of the National Rural Health Association. With that, I will turn things over to our wonderful team from the Flex Monitoring team. Thanks so much for being here.
Thank you, Tracy. So Our topic today is, as she said, is improving population health performance. This being an FMT presentation, we're also going to talk about evaluating population health initiatives. This session is designed to provide you with information and resources to help you develop initiatives to improve the population health performance of CAHs and the health of rural communities. Much of this material is based off of a policy brief and a companion inventory brief that the FMT published earlier this year. I'm going to start us off by sharing the findings from the inventory of activities that were proposed under Program Area 3 for the current funding cycle, including a description of 2 promising approaches for population health initiatives. I'm also going to mention some of the challenges relating to outcome measurement that we saw in the applications. Celia will then share examples of strategies that state flex programs can use to monitor the impact of their population health activities and assist CAHs in addressing rural health disparities. By the end of the session, we hope that you will be able to describe promising population health initiatives implemented by some of your peers, identify strategies to monitor the impact of those initiatives, including a chain of short, intermediate, and long-term outcome measures, and describe ways to connect flex program activities to efforts to address factors driving rural disparities in heart disease, cancer, unintentional injury and substance use, chronic lower respiratory disease, and stroke, which are the 5 leading causes of death in rural areas. Just a quick housekeeping note, please do use the chat box for questions, but we are going to hold them until the end. Next slide, please. So as you all know, FRHP has designated Program Area 3 Population Health as optional. It serves as a venue for state flex programs to engage critical access hospitals in population health activities, including chronic care management, clinical care coordination, and collaborative community programs to address the social determinants of health. States can choose to participate in one or more of the activity categories, which are listed on the slide. Our review of applications suggests that while each activity category can be done separately, and many states only implement 1 or 2 of them, taken together, they suggest a sort of stepwise process that can be used to build year to year across the funding cycle. Assessment planning work makes the most sense to do early in the funding cycle in order to identify and build on CAH strengths, address CAH weaknesses, and quantify community needs that can be addressed in subsequent years of the funding cycle. Obviously, states are not required to do that, but it can lead to a more comprehensive strategy that is more likely to improve population health than unconnected initiatives under any 1 or more activity categories. Next slide, please. Sorry. Thanks. So as I mentioned, we compiled an inventory of the types of initiatives that state flex programs proposed for the current funding cycle under Program Area 3. Our inventory brief lists these initiatives in the categories in which states originally proposed them. For the policy brief, we recategorize proposed activities to group them more consistently between states. If you're really interested in the methodology, you can consult both briefs, which are on the FMT website. After we adjusted the categories for consistency, we found that 31 state flex programs implemented 1 or more initiatives that fit under activity category 3.1. The most common ones focused on supporting CAHs in completing community health needs assessments through training, technical assistance, and distribution of community health data, analyzing the CHNAs or other assessments to share issues in the CAH communities and to inform initiatives in the other activity categories, and encouraging CAHs to take a population health readiness assessment to gauge leadership's understanding of population health concerns, as well as the hospital's capacity to address them. 34 states proposed programming that fit under activity category 3.2. The most common interventions involve training or technical assistance to develop strategies to prioritize and address unmet needs, followed by assistance to CAHs to formalize those strategies into action plans. Next slide, please. Finally, 34 states proposed initiative that fit under activity category 3.3. These initiatives addressed a range of community health needs, with the most common interventions focused on general health and wellness, behavioral health, chronic disease management, and the social determinants of health. States proposed to facilitate collaboration between CAHs and community stakeholders using data summaries and tools, educational opportunities, and engagements with local health authorities, state public health officers and payers, and other stakeholders. Notably, 9 of the 34 states indicated in their applications that they were waiting to determine which specific health needs to focus on until after they had worked with their CAHs to assess needs and determine priorities under activity category 3.1, which makes a lot of sense when you're considering activities across a 5-year cycle and you're proposing doing your proposal before you've done your data collection. Next slide, there we go. So reviewing all the proposed interventions across the activity categories, we noticed that the most common ones generally focused on providing basic education, technical assistance, and support related to the CAHNA process or population health readiness assessments. While these activities can be very helpful to CAHs, they do not necessarily represent a comprehensive strategy to assist CAHs in implementing evidence-based population health initiatives. It's also difficult to link these kinds of activities to demonstrable improvements in population health. When you look beyond these core activities to other initiatives in Program Area 3, we identified two promising approaches to supporting population health. The first involves engaging CAHs in collaborative learning cohorts focused on addressing population health issues that their communities had in common. The second, which I mentioned a couple minutes ago, involves implementing coordinated strategies in sequence through the activity categories across the years of the funding cycle in order to improve population health. I have two state examples I'm going to touch on briefly: Arizona, which laid out a funding cycle approach, and Colorado, which proposed a funding cycle approach using educational cohorts. I want to note that the pandemic did, of course, disrupt many planned interventions across the program areas. So what I'm going to describe is what was in their applications, not what they necessarily did. I also did want to add that if you're interested in using educational cohorts for your FLEX program activities, we did publish a policy brief about them in March of last year, and it's on the FMT website. So Arizona, as proposed in their competitive application, Arizona's work in Program Area 3 builds from one activity category to another, step by step over the course of the funding cycle, beginning with a statewide population and community health needs assessment conducted in the first year. In order to supplement this statewide data, Arizona planned to collect and synthesize the CHNA results from their CAHs in order to identify common community health needs and to align state-level health priorities with community-level needs. Building on this data in subsequent years, Arizona proposed to work with CAHs that requested assistance with community health activities and interventions. Specifically, Arizona planned to hire 2 health education and community outreach specialists who could support CAHs in prioritizing local needs and implementing strategies to address concerns such as access to care, behavioral health services, and healthy lifestyle factors, all of which fits under activity category 3.2. They also plan to work with CAHs to engage with their communities around population health and evaluate the program impact of local health initiatives, which fits into activity category 3.3. Colorado's application described the implementation of a project called the Colorado Rural Sustainability Network to help CAHs prioritize and address population health needs via a cohort-based chronic care management initiative. And some of you may have seen Colorado's presentation about it on Tuesday. In the first year of the funding cycle, Colorado planned to have interested CAHs complete a population health readiness assessment, with the results used to identify communities that were well positioned to implement population health projects. In subsequent years, Colorado planned to work with the participating CAHs in cohorts to implement chronic care management programs via peer learning calls, workshops, network meetings, and one-on-one coaching calls. As part of their participation in the network, cohort members were to target 3 national quality forum measures for long-term improvement among their patients: the rate of admission after discharge from the hospital for all-cause readmissions, the rate of patients with controlled high blood pressure, and the percent of patients with hemoglobin A1C levels greater than 9% during the measurement period. The cohort CAHs submitted the relevant data monthly via the Quality Health Indicators portal, and the recommendation adoption process model was planned to help monitor the progress of each community's action plan and to evaluate program impact. So speaking of program impact and data collection, I'm now going to turn to challenges we identified with how states undertake outcome measurement for their initiative. These challenges will sound pretty familiar, as none of these issues are specific to Program Area 3. One common issue we saw in the application is an over-reliance on process and outcome output measures and not outcome measures. Another concern is the confusion between output and outcome measures. A decent number of states listed output or process measures as their outcomes. Some examples are given on the slide, but as a reminder, in general, output measures are the direct result of your strategies or initiatives, your products, or your things you can count, while outcomes are measures that show program impact, often as an increase or decrease in something like skills, knowledge, or behavior. Another issue we saw involved the selection of outcome measures without a corresponding discussion in the narrative of data sources to support those measures, which can make it very challenging to demonstrate program impact. Finally, we identified a need for a clarification between the achievement of significant project milestones, such as the completion of CHNAs, and actual changes in population health, such as reductions in unnecessary admissions or increases in the number of patients with controlled blood pressure. The milestones are obviously really important for showing project progression, and in some cases, they can be useful as high-level short or intermediate outcome measures. But selecting appropriate outcome measures that demonstrate population level changes in the long term, those are what's really needed to demonstrate program impact. And with that, I'm going to turn things over to Celia.
Okay, thank you, Sarah. Hello, everyone. So referring back to Colorado's Rural Sustainability Chronic Care Management Program, the Colorado Flex program avoided the outcome measurement issues that Sarah just shared and offers a great example. When initially working with a group of critical access hospitals interested in the program, Colorado monitors the activities focused on assessment and planning. For example, they track the number of readiness assessments to identify which hospitals are equipped to participate in the CCM cohort, and the number of action plans that describe how the cohort will implement their CCM programs. As the initiative progresses, Colorado monitors the activities that support the cohort in actually implementing their CCM programs within their hospitals, such as tracking the hospital's participation in the CORES network and one-on-one coaching calls, and evaluating how well the hospitals are implementing their CCM programs using the recommendation adoption process or RAP model. For outcome measures, Colorado uses National Quality Forum measures to evaluate whether the program is achieving its intended impact. On a monthly basis, the FLEX program tracks the critical access hospitals' rates of all-cause readmissions and the provider-based clinics rates of patients with controlled blood pressures and the rates of patients with poorly controlled blood glucose levels through the Quality Health Indicators program. So by using these carefully selected output and outcome measures, it allows the Colorado Flex program to monitor how well the CORES network CCM program is being implemented and evaluate the changes in population health. When choosing outcome measures for your population health initiatives, we recommend you include short-term and intermediate outcome measures to connect your activities to your desired long-term outcomes. This creates a chain of evidence to document the impact of your program. Here's an example of a chain of short, intermediate, and long-term outcome measures for a chronic care management and prevention program that's targeted specifically for diabetes. These are measures that you or your critical access hospitals could use to evaluate if the program is having its intended impact. The short-term outcome measures measure the level of engagement of pre-diabetic and diabetics in the program. The intermediate outcomes measure change in patients' health, such as reducing the percent of pre-diabetic patients who develop type 2 diabetes and improving the control of blood glucose levels or other biometrics in the target population. The long-term outcome measures measure the impact the program has on reducing unnecessary hospital readmissions, emergency department use, and the number of patients with complications from diabetes. This example can be found in our latest population health evaluation brief that Sarah just shared the findings from. Now we will look at how the FLEX program population health initiatives can align with the U.S. Department of Health and Human Services Healthy Rural Hometown Initiative that was launched in September of 2020 through the Rural Action Plan. The Rural Healthy Hometown Initiative is a multi-program effort that seeks to address the factors that drive rural disparities related to the leading causes of rural deaths, which were mentioned earlier. The goals of this rural initiative are to demonstrate the collective impact the projects have on managing and preventing the 5 leading causes of death, identify and address the social determinant of health risks related to the leading causes of death, and highlight effective strategies. The 4-year initiative has 2 phases. The first is intended to align and target community-focused funding streams with the Federal Office of Rural Health Policy. to address the underlying factors that affect growing rural disparities. The second phase will work across the Department of Health and Human Services entities to leverage other programs and research funding streams. State flex programs can align with the goals of this initiative by encouraging hospitals to focus on conditions and factors underlying the rural disparities, and by developing programs that focus on things like health screenings, behavioral health, chronic disease prevention and management, care coordination, and screening for social determinant of health risk factors. Like the previous chronic care management examples, this is an area where initiatives are ideally suited for cohort-based, collaborative learning activities that support the implementation of common interventions and the reporting of common population health improvement metrics across groups of hospitals. Finally, efforts to engage critical access hospitals in addressing these issues align well with the Internal Revenue Service's tax-exempt hospital accountability requirements. And there's nothing in the State Flex Program Population Health Framework that prevents you from undertaking work that aligns with HRSA's plans to expand the Healthy Rural Hometown Initiative across other programs and funding streams. Fortunately, there is a strong body of evidence-based rural interventions to support you and your critical access hospitals. The Rural Health Information Hub provides links to nearly 60 examples of chronic care models that have been successfully implemented in rural areas. Although not all the examples are flex funded, they can provide ideas for what you can do. The examples on this slide and the last slide include in-person, community-based, and telehealth-based models to support widespread implementation based on local needs and resources. Some of these models, such as the Live Better, involve critical access hospitals. Although many of these programs target the general population, a number can improve health equity in rural communities by targeting the needs of underserved populations. Finally, we would like to offer you some ideas of how you can work with hospitals to address social determinant of health by using Z codes. Z codes are ICD-10 diagnosis codes used for medical claim reporting of social determinants of health. As you know, social determinants of health are conditions in the environment where people work, live, and play, and involve overlapping social and economic systems such as housing, food security, and transportation. Social determinant of health screening tools can be added to a hospital's electronic health record so that care team members can assess a patient's risk factors. Information collected by the screening tool may include things like preferred language, housing arrangements, work conditions, means of transportation, or one's ability to purchase medications or healthy food. This assessment can be done at various points along the care continuum, such as at time of admission to the hospital or during an annual physical exam at a rural health clinic. Once the social determinant of health data is entered into the patient's electronic health record, providers and coders can then assign appropriate Z codes. Reports on the Z code data can then be generated by the hospital's IT department and analyzed by clinicians and administrators to improve quality, care coordination, and patient experience. For example, by identifying individuals most at risk, such as those who are illiterate or non-native speakers, by identifying health disparities, such as trends in lack of transportation among racial and ethnic minorities or people with disabilities, by informing healthcare, for example, discharge planning of a patient with unsafe living arrangements or limited access to healthy food, or by triggering referrals to social services, such as low-income housing opportunities or local food banks, or informing value-based care opportunities, such as decreasing avoidable 30-day readmission rates by addressing the basic needs of a vulnerable population. State flex programs can support hospitals to build capacity to address social determinant of health needs by assisting critical access hospitals to develop training programs for leadership, the healthcare team, and coders. Leaders can be educated on how Z codes can be gathered and tracked, including electronic healthcare software capabilities and screening tools. or helping leadership determine how they want to use the Z-code data. For instance, do they want to enhance patient care, improve care coordination and referrals, support quality measurement, identify communities and population needs, or support planning and implementation of a social need intervention and monitor its effectiveness. Leaders can also be educated on how to design workflow to minimize the healthcare team's reporting burden and develop reports from screening tool and billing records. The healthcare team can be trained on how to use a screening tool, including best practices for collecting sensitive social determinant of health data, consistent documentation, and proper referral to social services and other support services. Providers and coding professionals can be educated on Z-code ICD-10-CM coding guidelines, and the link provided here takes you to a Z-code browser, which can quickly help you identify the proper Z-code to use. Once hospitals have the capacity to identify the priority needs, flex codes can work with the hospital to address those needs. For example, to address food scarcity, you could assist hospitals in identifying resources such as food banks, pantries, information about local or state programs, and facilitate collaboration with community partners to create more referral pathways. Based on the previous slide, here are examples of outcome measures you could use. The short-term outcomes measure whether the hospitals have incorporated the screening tool into their electronic health records and whether there is a change in knowledge among staff on how to best utilize the screening tool and Z-codes. The intermediate outcomes measure changes in use of Z-codes, referral to social services, and whether hospitals are analyzing the Z-code data to identify the priority needs within their communities. The long-term outcomes measure whether the hospitals are actually addressing the priority social determinant of health needs in their community and whether they have increased referral resources for those needs. So we hope this information will be helpful to you as you develop initiatives to improve the population health performance of critical access hospitals and the health of rural communities. Thank you for giving us the opportunity to share with you. And we'd like to now take time to answer your questions and listen to your comments.
Thank you so much, team. So if anyone has any comments or questions, feel free to utilize either the chat box. You can unmute your microphone and go ahead and ask, or if you're more comfortable, you can use the reactions icon on the lower part of your screen and use the raise hand feature, and we'll see that way. I do have a question though, and I was thinking about, actually, I'm just seeking more of a clarification or suppose there's some ideas. So I was thinking about the slide with short-term, intermediate, and long-term outcomes. And I know that's something we've been talking about for quite a while in the Flex program, but more so recently. The Flex monitoring team did a great webinar, a couple months back now, about outcome metrics for the operational and financial improvement area to kind of piggyback on the pretty obvious outcome metrics that we already have within the quality improvement area of the Flex program. And I've heard you talk that there is forthcoming information about population health metrics and maybe EMS metrics. Can either of you tell us a little bit more about what to expect with that?
Sure, I can jump in on that. We have two projects that are starting this July, which will be similar in format to the brief that we did on financial and operational performance improvements. So it's not ready yet, but we will be working on that, and that is they are priority projects for us because we know that that's useful. So it's underway.
Great, awesome. That'll be exciting, and I think helpful to many of us. So one other thing I was thinking about that too, like the slide where there was the short-term, intermediate, and long-term outcomes. I think so often in population health, the long-term outcome that we're aiming for is often, I want the health condition to be solved or fixed. And within the cycle of the Flex grant, that's not really realistic as a long-term outcome. So I really liked what you had on there about diabetes, like the long-term outcomes that you were suggesting on that slide were a reduction in complications or a reduction in unnecessary emergency department visits. And I think that's something that this is more of a commentary, I suppose, than a question. That's something that we all need to keep in mind, and we're working with our rural communities and things like that. We may not solve that ultimate health outcome with the community, but we can take those incremental steps with the short-term and intermediate, and even those long-term outcomes, if we think about them as more incremental steps, that gets us closer and continues the success and just saying, oh, we didn't fix the diabetes problem.
You know, Tracy, I think that's a good point. We find that with hospital administrators quite often. They'll talk to them about social determinants and of health and different chronic diseases, and they immediately jump to an eradication of the problem. And that's not what we're talking about. No one expects that. And I think because of that, hospitals tend to think they have a much longer term time horizon to fix anything. You know, we heard from a group of administrators recently that on the Flex, on our Future of Flex interviews, that they thought it took 5 to 7 years to implement a population health initiative. I'm not so sure I buy that, to be very honest. I mean, if you think about it sequentially, certainly long-term change takes a while. But if you think about population health or any flex activity in a series of steps where you identify the problem, you bring together a cohort of hospitals that are interested in working, begin to build capacity. So the capacity issue might be, how do they use their electronic health record to track diabetes in their diabetic patients or their hypertensive patients and the like. And then you set up steps, maybe it's a program, maybe it's clinical pieces. And these population health activities, it should be noted, can be either reimbursable services, which certainly chronic care management is, and I would encourage every hospital to think about doing that. It's silly not to, because that's an essential part of what communities need. Or the other piece can be done under their community benefit requirements, which the tax exempt hospitals are required to do. And some of those, you know, if they follow the community, the IRS community health guidelines, they're not, nothing in there is bad. Not all of the things that hospitals track are particularly useful. So if they started to do prevention activities, which have a very good return on investment, either in behavioral health or diabetes, those are things that they can do to create a more coherent strategy.
Yeah, excellent.
I think it also helps, you know, I think it was a very good point that to try and pick an achievable long-term outcome, but when you're thinking of your project, especially, it's like, what can you influence in the first year or two? And that's your short-term outcomes. It's what are you directly trying to influence? And then that's what you should really be trying to focus on, because that's what your project's going to do. The medium-term outcomes, you're going to be able to influence, but there's going to be other factors as well. And then hopefully you and the community as a whole, or your partners as a whole, will be able to influence that long-term outcome.
Mm-hmm. Yeah, absolutely. I've spent some recent time actually studying that previous presentation I mentioned about the operational financial improvement outcomes, and looking at the slides about the theory of change. And one of the things that really stood out to me, and it's just a great tool, is using those if-then statements. And it, you know, and that's that whole progression of your activity. If we dedicate these resources to it, if we dedicate the staffing, we bring these right people and partners to the table, and if these outcomes occur, then we can expect these sorts of short-term outcomes, or excuse me, if these outputs occur, then we can expect these short-term outcomes, and then on to intermediate and long-term. And that if-then is just a great kind of checks and balances for that whole process. Other questions for our presenters or comments?
Hey, Tracy, it's Gary Wingrove.
Hi, Gary.
The social determinants of health were created some time ago and adopted like 20 or 25 years ago by the World Health Organization. The world has changed a lot in that time, and I wonder if it's time for somebody to spend some effort on creating social determinants of health version 2. So that's just a kind of a bomb to throw out there. It doesn't maybe directly relate to this presentation, but it just seems like enough time has gone by, and certainly with what we're seeing in infectious diseases, if to validate that whether the ones we have are still relevant or could use some modification, and maybe there's 1 or 2 new ones we need to have in the mix.
Yeah, reactions from the panel to that?
I'm gonna let John answer that one.
Oh, yeah, it's a good idea, Gary. I think you're right. I mean, I think many of the basic issues still exist, particularly across rural and urban areas. We know education's a problem, housing, and especially in today's environment where housing costs have gone through the roof, that's a problem. But again, are there different things that we're looking at? So, and I think that's a good point. The other piece when looking at the social determinants is we fail to distinguish what the role of each of the different players may be. When we start talking about food insecurities, for example, there's not a chance that a hospital is going to solve that problem, but what they can do is at least bring it down to their community and their patient population. And that's where when hospital administrators express concern that, oh, you expect us to cure poverty or homelessness. And the answer is no, we don't. But what we do expect, what we do hope, I shouldn't say expect, that's not fair. What we hope is that you can understand how that social determinant, be it housing or whatever, affects your patient population. Part of that is screening. Part of it is being aware and understanding that homelessness, food insecurities, any of these things impact people's health. Then thinking about what is the right role. I mean, we don't expect hospitals to solve it, but they can be part of teams, and they can either be a convening resource to pull together community members. They might be able to do some linkages with the food bank to support their patients. And they can provide grant resources or grant writers to help fund community solutions. So I think you're right, Gary. It's both a combination of there are other things that we're seeing and hearing about, but no one's really captured. And then also thinking about how do we really make this practical for people on the ground? And that's what we failed to do with a lot of these high level discussions.
Yeah, absolutely. So Kathleen from Maryland put in the comments that just your point, Gary, was really interesting, and she's wondering if you can provide any example of a change that you see maybe in the social determinant of health set right now that you might suggest. Anything that comes to your mind, Gary?
Boy, I don't have any suggestions today, but I think it'd be a fascinating topic to spend some time working on. And like John said, it might be nice to even have a guide for how differing healthcare places might interact. There's a very large hospital in one state that partnered with a community group to start a grocery store that includes a community paramedic and a pharmacy in a distressed, ghetto kind of area. And so the Flex Monitoring team is really good about telling some of those stories, but sort of cataloging ways that can work would be good. And we spend a lot of time with community paramedics in their education program, trying to dial them into how best to help affect the improvement of the social determinants of health. And I just wonder if there's a way for us to do better, and if there may be some things that could be added to the list, but even a guidebook would be really handy.
Mm-hmm.
Let me also suggest something, and that is, even within the existing social indicators of health, are we really measuring the impact on our American population or on the rural population? So, for example, I just saw a report that's released saying drug overdoses have increased 29% nationally. And particularly when we look at our Black population, it's closer to 87, 90% in that regard. Mental health, the acuity level has increased as well. So while we have these indicators and they all are important, some become more important every year given the situation as such. So that might be another dimension in that meeting you're talking about, Gary. Maybe we could be looking at, okay, what is the strength of this particular driver of the social indicator at this particular point, and what could we do to actually address that?
And I think Kathleen's point is great about racial discrimination. And Terry, your point, I don't think we talk about it this way, but we've certainly recognized that social isolation is a huge driver of and community involvement are huge drivers of health problems. And I think, in some ways we might even consider living in more isolated rural areas as a disparity index. We know that it's difficult being a person of color, and in America, you have greater problems if you're a person of color with certain health issues, but if you're a person of color with certain health issues living in a rural community, your outcomes are even worse. And so understanding how that plays out, I think, is important, but we don't recognize it necessarily as a separate category. And I do have to give credit to two of my colleagues for influencing my thinking on this, Mike Meat, from Newark and East Tennessee State, and Alana Knudsen from Newark have been really talking about this for a while. So I think it's worthwhile, Gary, thinking about what's different and that may be a bit more actionable than we've found in the past.
Excellent. Well, that's fascinating conversation. I like the thoughts of, kind of the layering of issues and how we kind of have to bring that back down to the root causes of that. And then thinking about, what we've seen in my experiences working with some of the hospitals is you have to start at the very beginning and the things that are achievable to get the buy-in into population health projects right now. And this was even pre-pandemic. The pandemic just added the layer for the hospitals of another project right now to work on. But some of them really need those small places to start. I think that chronic care management is a brilliant place to start, and it's something very tangible that they already have some workflows likely around. And then looking at those good and easy and small wins at the first part, the short-term outcomes, and then moving further into the long-term things and getting in deeper into those layers, maybe, if you will. So I want to respect our time for a break too, and give you a chance. I know most of you have probably worked through your lunch hour the last few days, and we do have a little bit of a longer break today. So I'd like to honor that. So thank you to our fabulous panelists and our great partners at the Flex Monitoring team for presenting today and getting our wheels turning. We're on a break now until 1:45 Central Time. And at that time, then we'll be joining back with a link in the attendee hub for our afternoon sessions. And our afternoon is really going to focus on leadership and workforce. And we'll be diving into some excellent tools that have recently been released to help with the leadership challenges that are going on within our critical access hospitals, our small rural hospitals and clinics. And we'll be providing a teaser for you and some kind of a beginning peek at some resources that'll soon be available in the next month for the state flex programs to support your workforce challenges in your organizations. And then we'll close out the day with an excellent closing keynote on our roles, each as leaders, which I'm really looking forward to. So we'll see you back at 1:45 Central Time, or quarter to the hour in whatever time zone you're in, and look for the link back in the attendee hub. Thank you all.